cannot tolerate anticoagulation but in whom IVC filter is deemed necessary.
તમે કઈ રીકેપ કેવું નહીં આપો કે સીધું ચાલો
આ પેલા ડીવીટી છે ને હોય એના માટે
હા એટલે સર મેઇનલી બે જ ઇન્ડિકેશન છે in whom anticoagulation either contraindicated or cannot be used, or either in whom anticoagulation are already ongoing but still patient manifesting pulmonary embolism in case of DVT. So only there are two indications. In patient
કેવું છે જ્યારે વધુ આવતા આમ કે આવું તમે કીધું હોય ને ત્યારે જૂનો આમ થોડો 5 મિનિટમાં યાદ કરાવી દેજો
આગળની પડતા સાઈડ રીકેપ
કારણ કે અમે તો અમારા ઈરાન ને ઈરાકમાં બેઠા છે અત્યારે અમે હાલતું નથી
પસંદ બેઠા છે ઓલી ગયો
એને જવાબ કમ ઓન.
So in patient with acute PE who cannot tolerate anticoagulation, IVC filter can be useful to reduce the short-term incidence of recurrent PE, which is class 2A recommendation, and who cannot tolerate anticoagulation but in whom IVC filter is deemed necessary. In that case, retrievable IVC filter over permanent IVC filter recommended to reduce the short-term incidence of recurrent PE while minimizing long-term adverse outcome related to IVC filters. In patient with retrievable IVC filter, retrieval should be attempted as soon as the risk of PE has sufficiently decreased and anticoagulation tolerated in order to minimize the risk of long-term filter-related complication. In patient with indwelling IVC filters, the use of structure follow-up program is reasonable to increase retrieval rate and detect complication because many of patients lost follow-up after the IVC filter placement, which is class 2 indication. In patient with recurrent PE despite optimal therapeutic anticoagulation who are in AHA or SCC PE category B to E, IVC filter placement may be considered to reduce the short-term incidence of additional recurrent PE, which is class 2B indication. In patient with acute PE categories D to E and who are undergoing advanced intervention like systemic thrombolysis, catheter-directed lysis, mechanical thrombectomy or surgical embolectomy, the benefit of IVC filter placement is uncertain to reduce the short-term incidence of recurrent PE and mortality, class 2B indication. And in patient with acute PE who are therapeutically anticoagulated, routine IVC filter placement should not be performed. It is class 3 half. Systemic thrombolysis in acute PE. In patient with acute PE and acceptable bleeding risk in whom advanced therapy is being considered. In category E1 and E2, systemic thrombolysis is category 2A recommendation along with anticoagulation. It is recommended over anticoagulation alone to reduce the mortality and recurrent PE. In category D1 and D2, thrombolysis plus anticoagulation over anticoagulation alone is class 2B recommendation to prevent the further clinical deterioration. In class C, category C3, systemic thrombolysis and anticoagulation over anticoagulation alone to prevent further deterioration is uncertain. It is class 2B recommendation in C3 category. And in patient with acute PE being treated with systemic thrombolysis, lower dose systemic thrombolysis may be considered to reduce the risk of bleeding, which is class 2B indication. And category A1 to C2, systemic thrombolysis should not be used over anticoagulation alone due to increased risk of major bleeding and intracranial hemorrhage. So there are 4 small randomized controlled trial with total 224 patients with high risk PE reported that systemic thrombolysis therapy compared with anticoagulation with heparin alone leads to improvement in pulmonary obstruction accompanied by reduction in RV dilatation on echocardiography. So FDA has approved 3 agents for use in pulmonary embolism thrombolysis, includes streptokinase, urokinase and altiplase. Standard dose of altiplase is 100 mg in 2 hours is the most commonly used thrombolytic agent in patients with PE. Although there are no head-to-head trial of agent to suggest superiority of specific thrombolysis agent. Evidence is emerging that low dose thrombolysis, standard dose is 100 mg over 2 hours, while low dose like 25 to 50 mg altiplase compared with standard dose may be as efficacious and associated with reduced risk of major bleeding. Systemic thrombolysis associated with increase in major bleeding risk, in particular a greater risk of ICL. So patient with highest risk of mortality from PE and lowest risk of bleeding would obtain the greatest net benefit from thrombolysis, while those with lowest risk of mortality from PE and the highest risk of bleeding from the use of thrombolytic agent would obtain the least benefit and are likely to be harmed. Comparing catheter-directed thrombolysis and mechanical thrombectomy. In category E1 patient, it is class 2A recommendation, either catheter-directed thrombolysis plus anticoagulation to prevent further clinical deterioration and early mortality. Similarly, either we can use mechanical thrombectomy. It is reasonable to choose mechanical thrombectomy plus anticoagulation over anticoagulation alone to prevent further clinical decompensation and acute mortality. Class 2A recommendation in category E1 patient. In category D1 to E1, the efficacy of catheter-directed lysis over systemic thrombolysis is unclear. Class 2B recommendation. And the efficacy of mechanical thrombectomy over systemic thrombolysis is unclear, but mechanical thrombectomy may be considered over systemic thrombolysis to reduce the major bleeding risk. Class 2B recommendation. In category D1 to D2, catheter-directed lysis plus anticoagulation may be considered to prevent further clinical deterioration. Class 2B recommendation. Similar for the mechanical thrombectomy. In category C2 to C3, the benefit of catheter-directed lysis plus anticoagulation as compared to anticoagulation alone is unclear, and the benefit of mechanical thrombectomy plus anticoagulation as compared to anticoagulation is unclear in mechanical thrombectomy, also category 2B. And catheter-directed lysis is not recommended over anticoagulation alone for improving the clinical outcome or symptoms. In class 3, no benefit is there in category A to C1 patient, and similar for the mechanical thrombectomy. टू ए कैटेगरी E1 માં છે, બાકી 2B છે. કેટેગરી
કેટેગરી એટલે 1 કે 1B એપ્લિકેશન છે.
So small randomized control trial have demonstrated that catheter-directed lysis relieve RV dysfunction faster than anticoagulation alone, as measured by the RV-LV ratio. Major bleeding risk in this study with catheter-directed lysis was low. Patient with acute PE and evidence of RV dysfunction showing signs of impeding deterioration, category D1, D2, may benefit from reperfusion, and catheter-directed lysis may be an appropriate option. And the range of thrombolytic agent in catheter-directed lysis study has been 4 mg to 24 mg total over 2 to 24 hours, with reduced dose defined as less than 5 mg per pulmonary artery, and standard dose is 5 to 10 mg per pulmonary artery. Largest trial in high risk PE is the FLAME study, which is prospective multi-center parallel group design of 150 high risk patients with PE exhibiting characteristic of category E1 who either underwent mechanical thrombectomy or other contemporary therapies. And in selected patient from mechanical thrombectomy, primary composite endpoint of patient with mechanical thrombectomy patient having 17% incidence of the primary endpoint and 1.9% in hospital mortality in compared to other therapies where primary endpoint occurred in 63.9% patient and in hospital mortality was 29.5%. So benefit of mechanical thrombectomy over other therapies are there. Surgical embolectomy, similar to mechanical thrombectomy, they are class 2A recommendation in E1 category patient. So they are as compared to anticoagulation alone, it is reasonable to prevent clinical decompensation and acute mortality. In category D1, D2, also systemic surgical embolectomy plus anticoagulation may be considered over anticoagulation alone to prevent further clinical deterioration. And in category D1 to E1, benefit of surgical embolectomy to reduce short-term fatal or non-fatal clinical deterioration and improve long-term survival, functional capacity and quality of life over systemic thrombolysis is unclear, but it may be considered when there is risk of ICH, bleeding risk are there by use of systemic thrombolysis, then mechanical surgical embolectomy can be used, class 2B indication, and they are not recommended over anticoagulation alone for improving the clinical outcome in category A to category C3 patient, and those who are mechanical circulatory support like category E2 patient on ECMO. Surgical embolectomy is not recommended over other advanced therapy for preventing short-term mortality. This class 3, no benefit is there, category E2. So, modern pulmonary embolectomy performed on cardiopulmonary bypass, typically through a sternotomy with frequent need of aortic cross clamping, and bypass supports the systemic circulation and decompress the failing RV to mitigate the high mortality associated with pulmonary embolectomy. And cardiopulmonary bypass function by diverting venous return to the heart to a reservoir, pump and oxygenator, upon which it is returned to the arterial system. So physiologically, drainage of most of the venous return result in immediate reversal of the pressure volume overload that caused the RV failure associated with acute P. So this bypass, cardiopulmonary bypass allowing the RV to recover by permitting it to contract in unloaded state. Oxygenated arterial inflow supports and restores systemic perfusion and ECMO function in a comparable manner with a similar physiological effect on the right ventricle. So summary for advanced therapy. So in category E1, systemic lysis, catheter directed lysis and mechanical thrombectomy, it is class 2A indication. In category D1 and D2, it is class 2B recommendation. And in category C3, also it is class 2B recommendation, systemic lysis, catheter directed lysis and mechanical thrombectomy, while surgery is class 3, no benefits in above category C3 category. And in category E2, which is persistent cardiogenic shock or cardiac arrest, in which systemic lysis is only category 2A recommendation, while other advanced therapy are not applicable, and surgery is class 3, which is not beneficial in E2 category patient. So follow up after the acute P. So it is advised to follow up after the discharge within the first week to provide patient regarding the education, addressing the barriers to anticoagulation therapy, ensure adherence to medication and detect bleeding complication. So first follow-up is within the first week, then follow-up at or before the 3 months after diagnosis to discuss regarding the duration of anticoagulation, whether to extend the duration or not, review the need for further testing and assessing the symptoms of persistent pulmonary embolism related symptoms, and ask about P-related symptom and functional limitation at every visit for at least 1 year to screen for the CTEPD, chronic thromboembolic pulmonary disease, or other cause of dyspnea and functional limitation. These all three are class 1 recommendation, and in those with history of acute PE who remain on anticoagulation into the extended phase beyond the 3 to 6 months from the diagnosis, periodic assessment of the risk and benefit of continued anticoagulation is recommended to ensure the safety and efficacy of continuing anticoagulation. In acute P, use of general or disease specific questionnaire is reasonable to screen for anxiety and depression and follow up visit. In complex patient with acute P, it is reasonable to have follow-up care occurring specialized PE clinic if available to optimize the care, and who remain symptomatic 3 to 6 months after acute PE, it may be reasonable to obtain performance tests to quantify the physical limitation and identify which patient require more extensive evaluation. Regarding patient activity and travel, in patient recovering from acute PE, it is reasonable to encourage early ambulation rather than bed rest in order to reduce the risk of complication. Class 2A recommendation. In patient with history of acute PE, use of compression stocking during long haul more or equal 5-hour travel can be useful to lower the risk of DVT. In patient with history of acute PE related to travel or immobility who are not currently receiving anticoagulation therapy, it may be reasonable to use a one-time prophylactic dose of an oral anticoagulant or parenteral LMWS on the day of long-haul travel to reduce the risk of recurrent venous thromboembolism. Class 2B recommendation. For patient recovering from acute P category C2 to E, it may be reasonable to restrict long haul travel for 4 weeks after initiation of treatment to reduce the risk of adverse event. Class 2B recommendation. Now, anticoagulation beyond initial phase. So, they have mentioned we have to continue for initially around 3 to 6 months. Then after we have to assess whether need for further anticoagulation is needed or not. So the first acute P and no major reversible risk factor, continuing anticoagulation beyond the initial phase into the extended treatment phase is beneficial and category of recommendation is class 1. In patient with acute P due to major reversible risk factor, stopping anticoagulation at the end of initial treatment phase 3 to 6 months is recommended over continuing anticoagulation into the extended treatment phase in order to optimize the net clinical benefit of recurrent VTE versus bleeding. Class 1 recommendation. In PE due to persistent risk factor like cancer, continuing anticoagulation at the initial treatment phase into the extended treatment phase is reasonable in order to prevent recurrent VT. And in patient with P who are offered anticoagulation beyond the initial phase into the extended treatment phase, treatment with DOAC unless contraindicated is recommended over a vitamin K antagonist to reduce the risk of bleeding. So, PE with cancer who are offered anticoagulation beyond initial treatment phase into the extended phase, either DOAC or LMWH is recommended over vitamin K antagonist to reduce the risk of recurrent VT. And in patient with PE without cancer offered anticoagulation beyond the initial treatment phase into the extended treatment phase but have contraindication to DOAC, then vitamin K antagonist is recommended over aspirin or no therapy to reduce the risk of recurrent VT. For patients with PE who are offered anticoagulation beyond the initial phase into extended treatment phase, treatment with half dose apixaban or rivaroxaban is recommended to reduce the risk of bleeding. So the likelihood of recurrent VT after initial episode of PE depends upon whether that risk factor for VT was present at the time of initial PE, and depending upon factor, it may be divided into major reversible risk factor, minor reversible risk factor, and persistent risk factor, or if none are present, the absence of reversible or persistent risk factor. So risk of recurrent VT is low in patient with acute PE with major reversible risk factor, and anticoagulation may be safely stopped. In VT with minor reversible risk factor or persistent risk factor, decision to extend the initial treatment phase should balance the risk of recurrent VT versus the risk of bleeding. And risk of recurrent VT is high in individual without identified risk factor, and this patient should be considered for extended phase anticoagulation. So treatment divided into initial phase, initial treatment phase, and extended treatment phase. So initial phase in which acute, when first diagnosed, anticoagulants commence using regimen like apixaban 10 mg twice daily for 7 days, rivaroxaban 15 mg twice daily for 21 days, or more or equal 5 days of parenteral anticoagulation before starting dabigatran or edoxaban, or parenteral anticoagulation along with vitamin K antagonist until achieving INR ratio to more or equal than 2. This is the initial phase. That initial maintenance phase treatment follow it and continues for the rest 3 to 6 months. And after 3 to 6 months, we have to decide whether continue or discontinue the extended phase. So these are the major, minor, and persistent risk factors. Major risk factor like surgery with general anesthesia, more or equal 30 minutes, hospitalization for acute medical illness, more or equal 72 hours while confined to hospital bed, cesarean section, and lower limb fracture. Minor reversible factor like surgery with general anesthesia less than 30-minute duration, hospitalization for less than 72 hours, out of hospital acute medical illness more or equal 72 hours while confined to bed, hormonal therapy, peripartum period, and trauma with decreased mobility of more than 72 hours. And persistent risk factor like active cancer with or without ongoing treatment, autoimmune disease like rheumatoid arthritis, SLE, inflammatory bowel disease, and chronic immobility. Recurrent pulmonary embolism. In patient with history of P and who are still present with new symptoms and signs of suggestive of recurrent or breakthrough pulmonary embolism, radiographic imaging with either CTPA or perfusion scan is recommended to objectively confirm or exclude the diagnosis. In patient of documented recurrent P who have documented despite being treated with anticoagulant, and evaluation is recommended to detect clinical and pharmacological factors that may contribute to recurrent P. In recurrent P with adherent therapy, change to either alternative drug class rather than continuing therapy with the same drug. Documented recurrent acute P in patient with adherent with reduced dose of DOAC, it is reasonable to increase the full dose of DOAC in the same class. And in cancer and recurrent P which are adherent to therapeutic LMWH, there is escalation dose of LMWH by 20 to 25% is reasonable to prevent the future recurrent P. Class 2A recommendation. And evaluating ongoing symptoms following the acute P. So at every visit after the 3 months, we have to assess for the persistent symptoms, and we have to perform if symptoms are present, then we have to perform the non-invasive PET examination, chest examination, and if peripheral vascular disease limitation is there, is not there, then diagnosis is excluded, and if limitation is there, again we have to go for the transthoracic echocardiography or perfusion scan or CT scan, and if normal lung perfusion is present, then diagnosis is excluded, and we have to go for see for the other diagnosis for the symptoms related to dyspnea. And if abnormal lung perfusion scan or with low probability echo, then CTEPD is possible, chronic thromboembolic pulmonary disease, and then again we have to go for the non-invasive CPET, and if activity limitation is there, then we have to diagnose either CTEPD with pulmonary hypertension or CTEPD without pulmonary hypertension, and in those patients we have to further evaluate by pulmonary angiogram and right heart catheterization with or without exercise study. And if no activity limitation is present, then CTEPD diagnosis is excluded.